Welcome back to our AHIMA CHDA exam preparation course, where we are now exploring healthcare data analysis techniques. In this lesson, you will learn how to transition from simply storing data to actively using it to uncover meaningful clinical insights. Understanding these specific techniques is incredibly important, because this is exactly how hospitals improve patient care and reduce massive financial waste. Get ready to learn the actual mathematical formulas and analytical methods healthcare professionals use every single day. Let us jump in and start turning raw numbers into powerful information. And to truly solidify these concepts as we go, I highly recommend utilizing our practice tests or downloading the offline app to test your knowledge in real time. The very first level of analysis you will perform is known as descriptive analytics, which simply answers the question of what happened. When a hospital administrator asks how many patients visited the emergency room last month, you use descriptive analytics to give them a basic summary. This type of analysis relies heavily on simple counting, averages, and basic percentages to provide a clear historical picture. The CHDA exam emphasizes that descriptive analytics is the required foundation before you can attempt any complex statistical modeling. Once you know what happened, the next logical step is diagnostic analytics, which answers the deeper question of why it happened. If descriptive analytics shows a sudden spike in hospital infections, diagnostic analytics involves digging into the data to find the root cause. You might discover that all the infected patients were treated in the same surgical suite or by the same medical team. Diagnostic work requires you to connect different datasets together, acting like a medical detective trying to solve a complex operational puzzle. During your analysis, you will constantly work with two primary types of data known as quantitative and qualitative data. Quantitative data is strictly numerical, representing things you can explicitly measure, like a patient's blood pressure, their age, or their total hospital bill. Qualitative data is descriptive and categorical, representing things you can observe but not easily measure with numbers, like a patient's self-reported pain level or their religious affiliation. Knowing how to handle both data types is crucial, because they require completely different analytical approaches. To measure hospital success, analysts rely heavily on key performance indicators, widely known as KPIs. A KPI is a carefully selected, highly measurable value that demonstrates how effectively a hospital is achieving its most critical clinical or business objectives. Instead of tracking thousands of random data points, hospital executives focus on a dashboard of 10 or 12 major KPIs to understand overall performance at a single glance. The exam will definitely test your knowledge of specific healthcare KPIs and exactly how they are calculated. One of the most famous and important KPIs in the entire healthcare industry is the average length of stay, or ALOS. This metric calculates exactly how many days, on average, patients remain in the hospital before being safely discharged back to their homes. A high ALOS can indicate that patients are experiencing dangerous surgical complications, while a very low ALOS might mean patients are being rushed out the door too quickly. Financial departments monitor this metric obsessively because insurance companies often pay a flat rate per patient, regardless of how many days they actually stay. Another massive metric you must know is the hospital readmission rate, which measures how often discharged patients unexpectedly return to the hospital. Specifically, the government closely tracks the 30-day readmission rate for conditions like heart failure and pneumonia. If a hospital's 30-day readmission rate is too high, Medicare will actually penalize the facility by reducing their financial reimbursements for the entire year. As an analyst, you will frequently be asked to identify which specific patient populations are most at risk for these costly readmissions. To master calculating these critical operational metrics under real exam conditions, working through the realistic scenarios found in our practice tests or the offline app provides excellent targeted preparation. To understand how sick a hospital's patient population truly is, analysts calculate the case mix index, commonly referred to as the CMI. The CMI is a complex numerical score that reflects the overall clinical severity and resource demands of the patients being treated. A hospital with a high CMI treats very complex, critically ill patients who require expensive surgeries and specialized nursing care. Understanding the case mix index is vital because it directly determines how much money the hospital will legitimately receive from major insurance providers. Once you calculate these internal metrics, you need a way to know if they are actually good or bad, which requires benchmarking. Benchmarking is the process of comparing your hospital's specific performance data against external industry standards or national averages. If your hospital has an infection rate of 4%, that number means nothing until you benchmark it and discover the national average is only 2%. The CHDA exam tests your ability to select the appropriate external benchmarks to accurately evaluate internal clinical quality. To perform these calculations, you must understand the mathematical difference between a ratio, a proportion, and a rate. A ratio simply compares two completely different things, like the number of nurses compared to the number of doctors on a specific shift. A proportion is a type of ratio where the top number is also included in the bottom number, such as the number of diabetic patients divided by the total number of all patients. A rate takes that proportion and adds a strict time frame, measuring how often an event occurs over a specific period, like hospital infections per month. In public health analysis, you will frequently encounter two critical terms known as incidence and prevalence, and you must know the difference. Incidence measures only the number of brand new cases of a disease that appear during a specific time period. Prevalence, on the other hand, measures the total number of all existing cases of a disease in the population right now, regardless of when they were first diagnosed. If a new, highly contagious virus emerges, public health analysts will look at the incidence rate to see exactly how fast it is spreading. You will also need to clearly distinguish between mortality rates and morbidity rates when analyzing patient outcomes. Mortality refers directly to death. So a mortality rate measures how many people in a specific population died from a particular disease or surgical procedure. Morbidity refers to the state of being diseased or unhealthy, measuring the rate of sickness and clinical complications rather than death itself. Both rates are essential for evaluating the overall safety and effectiveness of a hospital's medical staff. When comparing the performance of two different doctors, analysts must use a crucial statistical technique called risk adjustment. Risk adjustment mathematically levels the playing field by accounting for how sick each doctor's patients were before treatment even started. without risk adjustment. A brilliant surgeon who takes on the most dangerous, complex cases would unfairly look like a terrible doctor because their patients naturally have higher complication rates. The exam considers risk adjustment to be a fundamental ethical requirement for any valid clinical comparison. Before starting a formal statistical test, analysts often perform exploratory data analysis, or EDA. Exploratory data analysis involves looking at a massive dataset without any specific questions in mind, simply searching for hidden patterns or strange anomalies. During this process, you might generate basic charts and graphs just to see how the data is distributed and if any obvious trends immediately jump out at you. EDA is the creative, investigative phase of analysis that often leads to the most groundbreaking clinical discoveries. A more advanced version of this exploration is called data mining, where powerful computer algorithms search massive databases for hidden correlations. Data mining can discover incredibly complex relationships that a human analyst would never notice, such as linking a specific combination of 3 different drugs to a rare side effect. Hospitals use data mining to identify hidden fraudulent billing patterns or to discover which specific patients are most likely to skip their upcoming doctor appointments. Understanding the concept of data mining is a key stepping stone toward advanced predictive modeling. Analysts must also understand the difference between retrospective analysis and prospective analysis when designing a clinical study. Retrospective analysis involves looking backward in time at historical data that has already been collected, like reviewing last year's patient charts. Prospective analysis involves designing a study today and carefully watching patients move forward in time to see what eventually happens to them. While retrospective analysis is much faster and cheaper, prospective analysis generally provides much higher quality evidence for medical research. To perform a focused clinical study, an analyst must first build a patient cohort. A cohort is a specific group of patients who all share a common characteristic or experienced a similar medical event during the same time frame. For example, you might create a cohort of all male patients over the age of 60 who received a specific heart medication in the year 2022. Accurately defining and extracting a clean patient cohort is one of the most common daily tasks for a healthcare data professional. During your analysis, you must constantly watch out for misleading mathematical illusions caused by confounding variables. A confounding variable is an outside factor that secretly influences both things you are studying, making them look connected when they are actually not. For example, a hospital might see a strong correlation between eating ice cream and getting severe sunburns. But the confounding variable is simply the hot summer weather causing both. Identifying and controlling for confounding variables prevents analysts from making wildly inaccurate and embarrassing clinical recommendations. Ultimately, the goal of all these analysis techniques is to tell a true, mathematically sound story about hospital performance. By combining descriptive statistics, accurate benchmarking, and careful risk adjustment, you can present hospital leaders with reliable facts rather than just guesses. You now have the foundational analytical tools required to calculate major performance indicators and investigate complex clinical anomalies. This solid grounding in descriptive and diagnostic analysis perfectly sets the stage for the more advanced statistical tests we will cover next. Congratulations on completing this highly analytical section of the CHDA exam preparation course. to effectively lock in your understanding of these specific formulas and analytical methods. I strongly encourage you to complete the attached practice tests right now. Or log into our offline app to quiz yourself on the move. Answering realistic practice questions deeply improves your long-term retention and is the proven way to guarantee your ultimate exam readiness. These practice tests and the offline app are built to support your learning journey every step of the way. Keep up this brilliant momentum. Stay dedicated to active learning. And I will see you in the next section where we tackle advanced statistics and predictive modeling.